Good afternoon and welcome to United TV. It's our Bariatric Friday session. Today is January 24th, 2025. As usual, Dr. Irgau is joining me today. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Thank you.
Today we are in our new cycle with Bariatric Friday. We are going to discuss why patients drop out of the program. So this is a really important topic for us because for a program which has like a daily case conference discipline, we see this very closely every time this happens. So today we want to kind of help those to understand what are the issues and how to overcome those problems. And if we can kind of start with what are the most common issues that you see that patient drop out, and then we'll go into the specifics of those.
Definitely. So it's a very important issue. As you mentioned, we see it in our program, but believe it or not, actually our program has one of the least dropout rates, when you look at the statistics around the country. So despite all our efforts, we still see dropout rates as well.
Mm-hmm.
And of course, we will come to the reasons that we see. But a bigger question that I would like us to look into a little bit, Kemal, is that why is it, when you have a treatment that clearly takes care of so many medical problems the person is suffering with, leads to extension of life, adding years to the person's life, adding quality to the person's life, why are people so reticent about it, right? We don't see that with other surgeries. When people come to my office and they've been recommended gallbladder surgery, they've been recommended surgery to remove a part of their intestine, or when the patients come to see our colleague, Dr. Vade, who does colorectal cancer, and patients have been recommended surgery to remove a cancer, there is no question. Patients follow up the recommendation to the teeth, right? In fact, their biggest question is, how soon can the surgery be done, right? And yet there is this. And in part, it has to do with the fact that we're still struggling to overcome this huge bias against obesity and its treatment, right? We are having still challenges in making people understand that we're not dealing with a lifestyle issue, we're dealing with a health problem. And with bariatric surgery, we have the most effective treatment when it comes to severe obesity. It has been proven, and bariatric surgery is one of the most scrutinized treatments for a number of reasons, and it's really safe, and the quality of outcomes has been proven to be very, very high. So that lingers over patients' heads very often. And of course, we see the specificities. For instance, one of the common reasons we see people dropping out is fear of complications, because obviously surgery elicits a certain degree of anxiety, and that, stops people from proceeding very often. And that's obviously different from other surgeries, as I mentioned, because, people are anxious when we recommend gallbladder surgery. People are anxious when we recommend cancer surgery, and yet they overcome that anxiety because the sense of importance of that surgery, overcomes that reticence, but that doesn't happen with bariatric surgery. So fear of complication is one of them. And the other one that I see very frequently is lack of support in their own, family or friends. Again, that lack of support comes because there is bias against obesity.
So that's kind of like the social stigma, maybe?
Totally.
Right. So let's elaborate that a little bit. It's like why maybe those family members don't really understand this, and how can the patient overcome that problem?
Absolutely. So the key here is that, if you have, loved ones, family members, friends who may not necessarily struggle with weight to the extent that the patient does, right? They will have a certain bias as to why that person is struggling, right? And very often, related to the stigma of obesity, they will probably think that that person doesn't have enough willpower to do it by themselves, right? That's how they look at it. And they look at surgery as a cop-out, as an easy way out, right? And so surgery is being looked at as a solution that is really an option that shouldn't be there because the person should be able to do it by themselves. When your loved one is really starting from that premise, then there's not going to be encouragement, definitely. And then there may be resistance even when you're asked them to support you. And this is a type of surgery that requires good support at home, not only obviously to recover from the surgery, but more importantly, to be successful in the long term.
Sure.
You do require that setup. And a lot of our patients have to overcome these barriers, and perhaps they've been thinking about surgery for a long time and they've never had really the courage to, pick up the phone and make the consultation because they were worried about this judgment perhaps or lack of support that they would have from their loved ones.
So in terms of financial barriers, and maybe we can include the insurance coverage. I'm going to actually just rephrase this insurance coverage, and then this is one of the things that I did in the earlier session today. So it's not an insurance necessarily, it's the insurance and employer coverage. So if whether or not the employer is providing that coverage, how do you see those financial and insurance issues, coverage issues for bariatric surgery, and what's the long-term fix for that?
So there are two issues here, Kemal. There is the real problem of insurance companies denying care when it comes to obesity care. And there is the perception of patients assuming that there will not be coverage because obesity care is not seen as a bona fide medical treatment, right? So if you are struggling with obesity and your perception is that this surgery is really not a medical necessity, then you may assume that your insurance company is not cover it. So that by itself, that perception by itself will stop you from taking the initiative to seek treatment because you're going to think, I cannot afford it. It's surgery, it's doctor's visits, and it's going to be expensive. I cannot do it. So that's the initial barrier, the perception, right? But that perception is created by a reality. And that reality is there is a bias against obesity care. And that also is reinforced by the fact that there are, even in this day and age, insurance companies who deny or put lots of obstacles in front of patients who are trying to get bariatric surgery. Let me give you examples of that. You may have an insurance company that outright excludes bariatric surgery from their plans, right? Or you could have an insurance company that encourages employers through different incentives to include bariatric surgery as part of the treatments that are offered, right? Or you could have an insurance company saying that patients have to fulfill X, Y, Z in order to qualify for bariatric surgery. So adding more and more barriers, So all these issues, rather than encouraging patients to seek care, they are putting obstacles. So how do we overcome that? Well, we have to advocate for our patients, and sessions like Bariatric Friday is really doing that to its own capacity, right? But it needs to be more. The community needs to be aware that obesity is really becoming the leading cause of mortality in our society, right? Because of obesity, this generation may be the first generation to have a shorter lifespan compared to its previous generation, right? Because of obesity, you have people in later life really suffering with cardiovascular disease, diabetes, kidney failure, and many other illnesses. And instead of spending the later years of their life with quality, they're spending them just going from hospital visit to hospital visit, right? This is what we have to educate people about. And then the other important part is that it's not easy to lose weight without effective help. It's not easy. No one can do it easily. Not even people who have all the resources are able to do that, particularly when obesity reaches a certain point, right? It is extremely difficult, if not impossible.
So today, as you guys know, we have two different case conferences. I start with the 8 a.m. with ACO and the 10 a.m. with bariatric. In the ACO case conference, there were actually back-to-back, there were two patients where they lost 20 BMI points. Now, our nurse actually marked the patient from the ACO side that morbid obesity still needed to be followed up, because after losing 20 BMI points, patient was still at 37 BMI. So started with 57. 57 BMI is a lot of BMI.
Yeah.
So, and then another patient, I think that it was about 18, if I'm not mistaken.
Mm-hmm.
And seeing these results are important for a group of people who are struggling with morbid obesity, and seeing these issues and then trying to actually remove these barriers during the process is really important. But one of the other problems that we see, not necessarily a problem, but maybe this is for us to be more precautious about how we are prepping the patient for the surgery. So there are some requirements that we want patients to go through, and for some patients, this can be kind of overwhelming, not understanding why they have to go through this. If we can kind of address this issue of why we need these steps to be completed before the surgery, and the important part for the longevity of the bariatric surgery.
Absolutely. So clearly, we have learned, Kemal, that good preparation from a medical point of view, from a nutritional point of view, from a psychological point of view, leads to great outcomes. Okay? And we have learned that the best centers invest time and resources on this. And they are rewarded with excellent outcomes as a result of that, right? Which means that when patients come to us, they come to us either with many comorbidities, illnesses. They come to us with different levels of understanding on fundamental things of nutrition. And they come to us also with different degrees of struggles with mental health, right? All things that need to be addressed properly if we want them to go through the surgery safely, and importantly, if we want them to be successful in the long term, right? Sure. So that preparation, however, Kemal, does not have to translate into very, very unattainable, long-winded requirements that very often we see with from insurance companies. So our intention is not to do that. In fact, far from it. So we do want our patients, for instance, to have screening for possible heart problems, and they may not have symptoms, but that screening is important because we want them to get through the anesthesia safely. We want our patients to have solid foundational nutritional education and evaluation, which means encounters with nutritionists. We want patients to be screened by a mental health counselor to make sure that if there are mental health problems, they are addressed properly and expectations are set in the right manner. We want to make sure that we know that patients don't have an ulcer in the stomach, or they don't have irritation in their food pipe. So we have to do something called endoscopy so we can have a look inside, right? So all that preparation is valuable and important, but it does not have to be done over 6 months. It can be done. In fact, our program is so well streamlined right now, particularly with the fact that your team does the case conference on a daily basis. You're able to support patients, and patients can navigate the system seamlessly. And support is at hand every time they have questions.
Absolutely.
With that investment, we're actually able to make it a lot easier. So I haven't actually found, especially in our practice, in recent times, any patient who has had difficulties navigating the system.
I mean, you and I, we have seen so many different programs around the country, and no other program has designated nurses assigned to a patient and have the daily case conferences. Right now, it feels like sometimes I feel like when we do these things in certain disciplines, I feel like this is for everyone. But then, while we were doing this with the hospital system, we were limited with once a month, only for brand new patients, and it would never be discussed again if the patient once is presented. So from that to daily case conference and seeing the process, having the designated people So we made this a lot easier for the patients, and that's one of the things that you mentioned earlier. The reason we have a very low dropout rate, we are about 50% better than national average. I believe 76% of the patients who start the program goes through the program, and that's, I believe, it's 55% nationwide.
Yep.
So, and we take this, and our understanding is very, different, and that's why we are probably better than other programs. And then also that's why we are able to do this with this process. Patients are able to go home on the same day.
Yes.
So that's, a lot of people still have difficulty understanding that, and yet that's what we have been doing, and that's what makes our program more successful. Now, question, in the office visits, patients, do they come with someone usually, or do they come alone? What's the norm that you see?
It's a mixture. It's a mixture.
Is it most like maybe 50% comes with someone? Or
yeah, I think they do. They do. I would say probably I would say the majority, though, probably slightly higher majority would come with somebody to the office.
Are they usually friends or family members?
Usually it's family members, but we do see
because their understanding is important, right?
Absolutely, absolutely. So, it's interesting because I actually encourage, particularly spouses, or parents, if they are young, the patient is a young adult. I don't actually encourage them not only to come to the visits, that we have with them, together, but also even go to the nutritional counseling sessions, with their loved one, so that their loved one can also understand. Apart from the fact that those teachings are actually very good for anybody, right? But actually, if they understand, their loved ones understand that, then they will be more supportive. And that support is very, very critical, right? But we do see some pushback. Sometimes we do see some loved ones who also are very reticent to support, and they will voice that even in the consultation. But very often, actually, I see that, things change by the end of the consultation when everything is explained. When we start talking about obesity and its implications in health terms, then people start understanding. When they start thinking, well, the reason, they have type 2 diabetes is when they started gaining weight. The reason they are taking blood pressure medication is when they started gaining weight. The reason they have sleep apnea is when they started gaining weight. All those things then become apparent. And then the issue of trying to control these symptoms one by one, whilst the obesity runs wild, it doesn't make any sense at all. Sure. It's like a patient I saw recently, relatively young patient in their 30s, very reluctant to go ahead with the surgery. But, the BMI is around 57, 58. The weight is around, high 300s for the patients who are in their early 30s now. So what is the prospect? If this is not controlled now, what is the prospect? And that's what we discussed, is that 10 years from now, that patient's weight, if unchecked, it's likely to be over 400. And once we reach the high 400, then even daily living becomes handicapped, right? So now you cannot go to any place without planning which city you're going to sit into.
Well,
right?
I mean, so Dr. One of the things, our body is so interesting, and in a way, sometimes so smart, but sometimes so fragile. If we have some small problem, like some infection on your foot, okay,
yeah.
Small infection, so life stops. Right?
Yes.
So if you have a little, if your eyelash, one of them goes in, that little thing just stops everything for you.
Yes.
You stop the train, right? So it's so crazy. Like if you have an ingrowing nail.
Yeah, toenail, yeah.
So entire energy is there. So then this is how kind of the responses that we get from the body. But when it's morbid obesity, the message is not that clear.
Yeah.
So at least this is, this is what the way that I see it is. The message is usually, you are tired, but you don't know why you are tired. Or you are not able to sleep, but you think that you have sleep apnea. Well, yes, you do because you have morbid obesity, but yes, you are not, I mean, you are tired not because you have hypertension. It's because you have morbid obesity, you have hypertension, your diabetes, all these, I think when for a small issue where it makes a huge, deal, for this big issue, I think our body is not really communicating with us. I mean, would you agree with that? Or?
Well, that actually goes to the heart of understanding the pathophysiology of obesity, right? We know that obesity creates a disease state. But when you look as to why our body allows that, there are ways to understand that, in that, the body that we have right now, the physiology that we have, does not really know how to get us to lose weight. It knows very well how to get us to gain weight. And if you think about it, as humans, for the 90% of our existence as humans through generations, it was very important for us to learn to gain weight rather than to lose weight because food was not available. So getting storage of energy was critical. And that's what our body did. Well, the key is now the transition we've made as a society of humans now with ready availability of food. Lack of food is not a problem for, at least in many places of the world now, which means that abundance of food now has not translated into change of our physiology, and it cannot, because these changes in physiology require much long time frames, essentially. But how does then the excess accumulation of fat really create so many illnesses? It's something that we are trying to grapple with. But I do want to take up one very important issue, and that is how people are unaware of the accumulation of weight over time. Right? There was actually a very interesting story that was told by a bariatric surgeon who he himself underwent bariatric surgery. And the story he told was that he never thought of himself as being very heavy. But you know what, Kamal? He never weighed himself. He never weighed himself until one day he found himself in an airport area for cargo. And they had these huge scales there for things. And he just said, you know what? I'm going to weigh myself, because he always thought that the small scales would not give him the right answer. So he was really ignoring the problem, right? But he said that he went on the scale and he almost fell because the scale read 460 pounds.
Oh my.
460 pounds. And he did not think of himself as heavy at that time, right? So there is a certain level of, not really following up, because we're looking at ourselves in the mirror every day and we don't see the changes, right? Until we see it, right? And that sneaking type of the weight is what gets people really, to suddenly wake up one day and say, hey, I'm having a hard time, putting my shoes on, or I'm having a hard time reaching my back with my hands, right? And then suddenly all other things come together as well. The fact that they're taking lots of medication for different illnesses, right? But at that time, we have to be ready to help them. The last thing they want is for us to put barriers, right? Whether you're an insurance company or whether you're the loved one, that is a time when we need to say, yes, this is a serious health problem and it requires a serious solution. And bariatric surgery is that. It's a serious solution, but for a very, very serious problem.
So that's being used to certain things, right? Like that's what I was saying about the case conference. Like when we do it daily, I feel like everyone is doing it.
Yeah.
So then we get used to it. So then I think when you see yourself every day and not realizing you may be actually gaining weight, unless you are weighing yourself. So I can see how that can happen. But again, the issue of our body not telling us strongly, hey, this is what's happening and it's going to bother me long term. Like the ingrowing hair, like, how much pain?
Yeah, of course.
Like your life stops until you take care of it.
Yeah.
But you have morbid obesity and it's passive. It's not doing anything.
Yeah.
I think the body needs to get a little bit smarter. Are there any foods that can make us smarter? No. Okay. So now, One of the things that I want also our audience to know that we have a lot of patients who drop, but then they come back.
Yes.
If I have to guess, at least 25% of the people who drop, like in the last 18 months, they come back. The problem is every time they come back, they gain a little bit more weight.
Yeah.
I haven't seen one single patient who lost weight after the last consult.
Yeah.
And now, like they were 43 and then now they're 40 BMI. I haven't seen that.
You don't.
So now knowing that there's a fear for surgery, financial challenges, going through the surgical clearance process and not having enough support, expectations that we set for ourselves, and some of the other perhaps conditions that we may have. These are part of what we have to deal with, and it's part of our life. So the important thing is what also our life is our own body, and then we have to take care of that in the best way that we should for the longevity of our health, our well-being, and also having quality time with our loved ones. So this is not a cosmetic surgery. This is a very important surgery that actually fixes the chronic problem that we have. And I'm hoping that those who are looking for solutions, they can find us on YouTube or come to our offices and then see how much availability we have and then how much support we have, so we can help and make their journey much better and successful. So, Dr. Irgau, thank you so much for joining me today.
Thank you.
We'll have another live session next week, and then we'll have a couple of weeks break after that. But we'll still have videos playing at the same time. So we'll be back with another topic Friday the 31st. We'll see you soon. Well, thank you again.
Thank you. Bye-bye.
Bye.